Hello Brain Shakers, welcome to the Brain Shakers Academy. Your host here, Brave Alistair. In today's session, we continue looking at hypertensive disorders of pregnancy, and in particular, today's session is looking at the pathophysiology of hypertensive disorders of pregnancy. What happens behind the scenes of hypertensive disorders of pregnancy. And so basically that's what we're going to be looking at. Now let's quickly dive into today's session and understand the happenings in the background of a hypertensive disorder of pregnancy. So we understand already that the theoretical understanding of the origin of a hypertensive disorder of pregnancy is placenta related. It means that it has to do with the placenta, and this is why once a woman has then gone on to deliver and the placenta has been delivered, the blood pressures then begin to normalize. Now, what is happening in normal placentation? And if you haven't watched a video, I have done a separate video on the formation of the placenta. And if you want to understand the nitty-gritties and the details of how a placenta forms and embeds the uterine decidua, you will find that video on my YouTube channel, and I will add some links as well to those videos so that you can access them. But in a brief, I'm just going to quickly highlight what is happening during a placentation. So in normal placentation, you will find that the trophoblastic layer is going to invade the decidua. So if you have a uterus here, and then you have what we call the trophoblastic layer, and this trophoblastic layer, we did call it the syncytial trophoblast and the cytotrophoblast because it then divides into two. And what you have on the outer aspect is the syncytial trophoblast, which then begins to invade the decidua by invading first the endometrium before it can then get to the myometrium and completely buries itself in there, so that you have now a well-formed placenta and well-attached placenta. Now, with uterine invasion, in most cases, you find that if this is the decidua here, and then on the back aspect here, you are going to have so you have a lining here, which is going to be the decidua, which is the endometrium here, and then you have the myometrium before you get to the perimetrium. Within here, you have what we call the spiral arteries. Now, these spiral arteries are coiled blood vessels, and because they are coiled blood vessels in there, these coiled blood vessels have to be invaded by the syncytial trophoblast. And once the syncytial trophoblast invades these spiral arteries, then they are straightened and they become more relaxed. Why? Because there's remodeling that happens. The remodeling of these spiral arteries to make them flaccid and straight is to allow more blood supply now to come to where the placenta is going to be situated, so that the flow to the uteroplacental unit here is established. Now, in the case of a normal placentation, you find that the syncytial trophoblast will be able to invade these spiral arteries and form a formidable joint where the placenta now can easily hold. And that is why we also look at the types of placenta invasion abnormalities. And I did another video where I look at accretors. You can also find it on the YouTube channel. Now, with the syncytial trophoblast invading these spiral arteries, it will then remodel them, and then they become flaccid. They become like this and open up, reducing the resistance there, meaning that the low resistance that has been created allows the blood now to flow to the uteroplacental unit. Now, as this is going to be happening, what then happens in the abnormal placentation, which of course hypertensive disorders of pregnancy is associated with, is that this syncytial trophoblast that is invading these spiral arteries will not invade the spiral arteries all the way, meaning that it will just invade the spiral arteries superficially, meaning just a tiny amount of the syncytial trophoblast is going to invade the spiral arteries, meaning that it doesn't go any further to invade into those spiral arteries. Why? Because it has been inhibited. Now, this inhibition, we'll look at it when we look at the maternal immune response that is then generated once there is a fetal antigen that is presented. So the inhibition of the invasion of the spiral arteries by the syncytial trophoblast will make this placenta now that is going to be formed not to be a well-nourished placenta, because you still have a major portion of those spiral arteries uncoiled, meaning that they are still spiral on the other end. It is only a smaller portion here that is flattened, meaning that the supply also to the placenta is going to still be affected. And this then has complications where you end up now having a fetus here that is not well nourished, a fetus that is not going to grow well. You have intrauterine fetal growth restriction, and this placenta, because it is not well fixed and not well nourished, it has higher chances of then abruptly coming off when you have a raise in the blood pressures. So hypertensive issues now will bring you to most likely an abrupt placenta, and then you end up, in terms of fetal complications there, you will have an intrauterine fetal growth restriction, and that would culminate also in an intrauterine fetal death, because this placenta is not well nourished, meaning that the fetus in there is not getting adequate nutrition from the lack of maternal supply through those spiral arteries, which in a natural and normal sense were supposed to be dilated like this so that there is adequate supply of blood that is coming to where the placenta is going to be. So it is a failure of the placenta now, or the syncytial trophoblast, to remodel the spiral arteries, or to invade into the spiral arteries and remodel those spiral arteries for blood supply to then be adequate and be supplied to the placenta. Now, it is theoretically documented as well that there is a fetal antigen that is present and expressed on the placenta, and because of that fetal antigen that is expressed on the placenta, there is a maternal immune response that is then generated because of that fetal antigen. Now, I look at the major histocompatibility complex when I look at immunology and antigen presentation in another video. So if you haven't subscribed to the YouTube channel, do subscribe so that you can also understand that concept of immunology, where we talk about issues to do with the MHC class 1 and the MHC class 2 as well. Now, this fetal antigen that we are talking about that is expressed on the placenta is going to then force, so we have what we call a fetal antigen, which is believed to obviously be expressed by the placenta, is then going to generate what we call the maternal immune response. Okay, so this maternal immune response is going to respond to this fetal antigen by producing toxins. So this then responds by way of toxins. Okay, now these toxins are going to then cause a damage to the endothelial cells. Okay, the toxins that are then released to come to react to this fetal antigen that has then been expressed by the placenta, obviously expressed from the father of the child, then is going to cause a damage to the endothelial cells. Now, what do the endothelial cells do? So the endothelial cells are what lines all manner of blood vessels. So whether you're going to the brain, whether you're going to the kidney, any other blood vessel, within the lining of the blood vessels here, you will find these endothelial cells. And why are the endothelial cells in there? One is to facilitate, so they facilitate transport, meaning that they facilitate the transportation of blood within the vessels here, and then they also regulate the integrity of the vessels here. So they are maintaining the integrity of the vessels. Number 3, they are regulating the smooth muscle contractility. So within the tunica media of the vessels here, they will regulate the smooth muscle contractility. So meaning that the contraction and the dilatation of the vessels is then regulated by the endothelial cells here. And then the other thing that these endothelial cells do is they prevent coagulation. Okay, the blood that is circulating through those vessels there will be prevented then from clotting. The other thing that the endothelial cells here are going to do is that they are going to cause the production of nitrous oxide and prostacyclin. Now, nitrous oxide and prostacyclin are the ones that are responsible for making sure that these vessels are dilated. So this is the role of these endothelial cells in terms of their presence in the vessels. Now, the immune response there that has been generated is coming to cause a destruction of these endothelial cells. Then what is going to happen when these endothelial cells have been damaged? So when these endothelial cells have been damaged, we already have these vessels here. And if we have a vessel here, this vessel now has no endothelial damage. Think of what is going to be happening in the brain. Think of what is going to be happening in the kidneys. Think of what is going to be happening in the liver. You have what is going to be happening in the eyes. You have what is going to be happening in the heart, then in the blood or circulatory system itself, and think also what is going to be happening with the clotting responsibility of the blood. So the endothelial damage now, so